Hello, students, and welcome to Healthcare Systems and Health Policy. My name is Dr. Barbara Dantzler, and I am one of the course mentors for Care of the Older Adult. This presentation goes along with one of the 9 competencies identified in your course of study. It is developed to supplement the material that you are receiving in your course of study and provide another format for learning. I hope that you will get additional information that you need to master this competency. Watch this recorded video as much as you like and need. As always, we course mentors are still available to assist you live and one-on-one. So let's begin. Healthcare policy. For those of you who have not been on this side of healthcare, this information will be very informative for you. Healthcare is not immune to the effects of politics. Politics is in everything, as we already know. Policies are being addressed every day that impact how healthcare services are being delivered. It is advantageous for the nurse to be abreast of the key changes that will affect your work environment and the patients that receive the care. Behind the scenes, many organizations and groups, patients, and healthcare consumers and nurses are lobbying for different healthcare needs. They are going to state capitals, they are going by the busloads, and they're even going to Washington, D.C. They have a voice and they have the right to be heard. And so they go and they lobby for healthcare policy changes and healthcare reform. Nurses, you play a strong role in patient advocate in this venue, and you as well can lobby for changes not only for your patient, but for yourself and your work environment as well. So we are focusing today on the older adult. And with the baby boomers now at 65, not all of them, I'm one of the baby boomers, I'm on the tail end, so I'm not 65 yet. However, hopefully I will be one day. There are a lot of key findings related to the health workforce that include some of the things like most healthcare professionals are receiving or have traditionally received limited training on the care of the older adults. Until recently, the total picture of how the baby boomers will impact the healthcare system had not been investigated. But now it is evident they will change the healthcare scene dramatically. And unless properly addressed, they will cause a public health crisis. One, there is a decreasing number of available healthcare providers. As they age themselves and retire, there are not as many going to be available. They are also aging rapidly. And because of this, we have a limited number of healthcare providers that will be available to take care of this ever-growing number of older adults. Many health professionals lack diversity or diversity training. Not only are the older adults as a whole, their numbers are increasing, the dynamics of this group is also changing. Minority older adults are also increasing, and there is a need for more diverse professionals and diversity competent healthcare providers. Future shortages of healthcare workers to serve older adults are likely, and there will be a future demand for these healthcare professionals. And the paraprofessionals, we won't forget about them, to also take care of the older adults. All this is also going to be affected by health insurance reimbursement policies, which we'll get into a little bit further in this presentation when we talk about Reform and Affordable Care Act. Emerging technologies, which is one of the reasons people are living longer and healthier lives. New models of care are going to be an issue and presented, and changes in profession-specific scopes of practice. At the same time, older adults consume a disproportionately large share of the American health care services. So demand for health care services will grow. The aging of the population will also affect the nature of the skills and services the healthcare workforce must be equipped to provide. And it will also change the settings in which we provide healthcare services. some more impact about the healthcare delivery these older adults will have. There will be a creation of, there will be a creation of new positions and new jobs and new titles to deal with this growing population. I've only mentioned a couple or a few here, but I'm sure there will be much more, and you will find more information in your reading that is in your course of study. We will just talk about a couple here. One is Life Care Plan, or the Certified Nurse Life Planners. This is a new, relatively new title and position. So you out there who are considering staying in nursing, but maybe changing your field or profession in professional focus of nursing, this might be something for you to consider. The Life Plan, Care Plan, is a comprehensive document to help meet the long-term, not just physical needs and health needs, but the financial needs of the person who has experienced a catastrophic injury. Now, normally we think about that as someone who has been in a car accident, or younger person, and has been paralyzed. And so a plan is put into place to help with what we are going to do for the person. Life care planners generally develop plans for insurance companies or lawyers representing the client, but the ultimate goal is to promote the best outcome for the person for whom the life care plan was written. So here's a good position: Certified Nurse Life Planner, CLCP. They have to earn 128 continuing education hours, and they must complete a successfully complete a sample life care plan and pass an examination. Okay. And in addition, this is organized to the point where there is a board of American Association of Nurse Life Care Planner certification. It is the board for them. So this is not something that's fly by night. It has been established and organized, and something for you to consider. In addition, with this, the seniors are not only just living longer, but they continue to participate in higher risk activities today than any generation in the past. The rate of catastrophic accidents formerly considered to be prevalent among young adults may now be seen with older adults because they are doing the same things they have done earlier in life. I'll give you a real life example. I have members of a national motorcycle club that I am a member of. It's a non-profit charity organization of motorcycle riders that represent a historical a group. And we have riders that are 73 years old, and our rider, one of our oldest riders, is 86 years old. He is still riding his motorcycle. He is still ambulating without any assistance. And he did have a catastrophic accident. However, he recovered completely from it. Someone hit his bike from behind while he was at a standstill. It broke his pelvis. And you would think someone in their 80s would not recover as he did, but I think he was in pretty good health prior to that, and he recovered quite quickly and is now back on his bike, or has been for quite some time, and does not use anything to help him ambulate. But because of being active in those types of activities, still, they are among those who a life plan for catastrophic injuries is applicable to. Other things like horseback riding and skiing, and they're still driving their cars and operating machinery well into their 90s. So also, the other thing that affects older adults and may also generate the need for a life care plan is the chronic debilitating illnesses that continue to affect you as you get older. Another field is the need for financial gerontology. This is when you combine gerontology and financial situations, and you combining the knowledge and skills of both to develop a plan that is being managed by an expert, and it is also designed to meet the unique financial needs of the older adult. And there are some practitioner and academic components of that. And of course, we are all more aware now of long-term care insurances. Our employers are offering that to us because we are living so much longer, and because of the possibility of having a disabling disease and illness and need some extra care during your later years in life. Long-term care insurance seems to be a pretty smart way to go. The other thing is, because of the growth of this population and the technologies and the changes in insurance repayments, different living environments is where healthcare may be delivered. Not always now will it be in a long-term care facility. It could be in the person's home. It could be in a group home, assisted living. There are a wide variety of areas in which you may find yourself delivering healthcare services to one of your clients. So all of this will be impacting healthcare delivery. And in addition, because of the growing number of elder adults, they have created the Elder Bill of Rights. Now, keep in mind, the Bill of Rights and the Patient Bill of Rights are still the same and applicable to an older adult. But this was completed to address those special needs of the hospitalized older adult. And it's more detailed and focusing on quality of life for them. You see the little Hartford Institute of Geriatric Nursing here, which is something that you have been using throughout your course of study, or if you have not began that, you will be seeing this all the time. And so they have on there, and you can find it in your Hartford Institute website, the Elder Bill of Rights. I've given you a little example here. I'm not going to read over this entire rights and expectations, but you can find this on their website, and you will want to read that as well. The second slide just continues it. There are 5 ones that are unique to the older adult. And so this is worth reading over and writing it because it's quite detailed. Like staff will listen to and answer my questions truthfully and honestly and in a way that I can understand, and look at what the staff will do. Staff will help me and give me time to ask questions about my care. Otherwise, be patient. Give them time to process their thoughts. They will help them write down what they want to remember. If I am nervous or afraid and unsure, they will help me with these feelings. This is a big commitment here, but it is geared toward the things that an older adult deals with when they are in the hospital. I mean, it is, bad enough when you're younger and you're in a hospital, but consider an older person who has different needs and a different outlook on things and could get confused easily because you've changed their environment or it's a traumatic experience. This is very important that someone understands that they need to allow them time to answer questions, to treat them with dignity and respect, to allow them to express their feelings and to be there and to listen. And then someone needs to explain it to them in a form that they can understand. So let's begin with the interesting facts of Social Security. The Social Security Act of 1935 was established in the United States, and it was a federal old age pension program. And the United States was one of the last industrial nations to establish such a thing. So we were a little bit behind everyone else. The Social Security Act provided a safety net of income in return for a lifetime of employment. So if you worked all your life, this was your safety net of continuous income, so that you have some sort of income after you quit earning, a salary. But it was never intended to be the sole source of retirement income. Benefits are financed by payroll taxes. You see your paycheck, and it looks like half of it is gone. It's your Social Security tax, FICA, and all that other stuff. And it's paid by you, and it's available at your full retirement age. and it's based on the workers' average index monthly earnings. And it is covered employment employers on income up to a certain level. Since 2003, the full retirement age has been rising, as we know. It set a standard by which we could look at what time a person at what age a person would retire, and you can get your full benefits if you go until you have completed getting your delayed retirement credit. So, for example, if you postpone your retirement, you say you can retire at 65, but if you postpone your retirement to the age of 70, you'll get more than your earned benefit. In other words, you'll get a little extra. But if you retire at 65, you get a smaller amount of Social Security. And I have noticed that could be anywhere between a $600 to $800 a month difference in 5 years of retirement, either at 65 to 70. So I guess it's in your best interest, if you are still viable and you can still work at whatever position you have taken, it might be in your best interest to get all of your money to retire a little bit later. However, I have heard others say that they want to take their Social Security as early as possible because they're not sure if it's going to be available at a later point. I'm not sure about that either way, especially with us who have not gotten that close to retirement. I think that if you are viable, you should probably go ahead and get it, because you're going to need that $800 difference or whatever it may be with the way the economy is going now. But that is just a little bit about Social Security. You can read a little bit more detailed information in your course of study in your e-text. Medicare. Medicare is quite complicated for a lot of our older seniors to maneuver and navigate around to make the choices, and we'll get a little bit into this. Medicare is Title 18 of the Social Security Act. So it is connected with Social Security. It is connected with retirement. It was passed in 1965. And what it is a federal health insurance program. Federal health insurance program for people 65 years or older, or certain people with disabilities and people with end-stage renal disease. Okay, and as you can see on the slide, it tells who can get Medicare for free, and who are over the age of 65. So if you're over the age of 65 and you retired from the Railroad Retirement Board, you can get your benefits. You're already getting benefits from Social Security. You're eligible for your benefits from Social Security or from the railroad benefits, but you haven't filed for them yet. You're still eligible to get Medicare for free. Or your spouse or you had a Medicare covered government employment. If you are under 65 and you receive Social Security or the retirement bill benefit from the railroad disability for 2 years, or you have end-stage renal disease and meet other qualifications. Medicare is a federal program, so it is basically the same everywhere in the United States, and it is run by the Centers for Medicare and Medicaid Services. And these are federal agencies, federal government agencies. It's financed by payroll taxes paid by the employer and the employee. Part A helps covers your inpatient care in hospitals, critical access hospital, and skilled nursing facilities, but not custodial long-term care. Okay, so it will cover hospital, critical access hospital, skilled nursing care. When you see I have SNF here, that means skilled nursing facilities. And if you are in a nursing home, yes, it will cover the person if they have a skilled service, meaning they need some medication or rehab, or at that point, not just for custodial care. There is a hospice waiver as well, and in certain circumstances, home health services will be covered as long as the person has a skilled service need in home. That means they will have either a RN coming in to do some type of service, or they will have physical therapy with a physical therapist coming in to do some type of rehab services. Medicare will cover the home health services. So if you put in a home health aide under the RN or under the therapist, then Medicare will reimburse them for that. However, if it comes a point in time where the skilled nurse or the physical therapist is no longer needed, Medicare will not cover the home health aide or any other services or durable medical equipment that is provided. Okay, so you don't have to know these details, but this is an information to let you know if you're dealing with your patients and you're going to send them home. It depends on what you're sending them home with as to what type of services they can receive. When we get to Medicaid, you will know that Medicaid can take care of home health aid services without a skilled services in certain states. And we'll talk about that in a minute. Let's continue. So you must meet certain conditions to get the benefits that cover your hospital stay, and you can get a semi-private room. It won't pay for a private room, but they'll pay for a semi-private room. Now you can get a private room if your diagnosis warranted. Say for instance you have MRSA, or you have C. diff. Then of course they're going to put you in a private room because you are highly contagious, and we don't want C. diff and MRSA spreading throughout the hospitals. So Medicare would cover that type of private room. Okay, it covers the meals, it covers general nursing care, it covers drugs that are part of your inpatient treatment. So you're not going to get any special drugs that have nothing to do with your treatment. All this must be clearly documented. Everything must match up. There are those who review these cases, and if they don't match up, if there's a medication that isn't normally a part of the treatment for this particular illness, Medicare may or may not cover it. It just depends. You get it to cover your treatments of any type and any other supplies or services that you receive in the hospitals. So this is your acute care hospitals, your critical access hospitals, your inpatient rehab facilities, your long-term care hospitals, inpatient care as part of a qualifying clinical research study, and mental health care. What won't be covered by Medicare Part A is private duty nursing, private room, as I said before, and get this, not a television or a phone in your room. If the facility you are in charges separately, it's not, in the package of the room. Back in the day, you used to have to pay for your TV to come on in your room. Everybody had the little individual TVs, or they had the big TV, but if you wanted TV, you were supposed to pay for it unless you had a roommate who paid for it and didn't mind sharing the TV with you. It was another fee. It was not built insurance, so you had to come out your pocket and pay whatever $3-4 a day or whatever the cost was to have the television on. So if it's still, and as well as the telephone, you had to pay an extra amount for the telephone. I know that sounds crazy for you younger people because it seems to be a normal part of every hospital room, but at one point in time, access to telephone and TV was considered something like a luxury, and it was not covered by Medicare or any insurance because it was billed separately. So you can think about that. And personal care items are not covered by Medicare, such as your razors and the socks and I guess deodorant and so forth. So your family members need to bring that in for you, or you're going to be sharing a cost of it with your hospital stay. And I guess if you can go to the dollar store and get 10 razors, it'll be a lot cheaper than paying $40 for one plastic disposable razor as what the hospital will bill you for it. That is something to consider with Medicare. Okay, Medicare Part B is your medical insurance. Okay, it covers doctors' services, outpatient care, and other medical services that Part A does not cover. Services or supplies that are needed to diagnose or treat your medical condition and that meet accepted standards of medical practice. Okay, coverage is optional. You do not have to have Medicare Part B. It is an optional coverage and it is paid out of your Social Security check. So the premium is a monthly premium that is deducted from your Social Security check before you even see it to cover the cost of Part B Medicare. Okay? It can cover things like clinical research, ambulance services, durable medical equipment, mental health, whether it's inpatient, outpatient, or partial hospitalization, getting a second opinion before you have surgery, and it will cover a limited outpatient prescription drugs. Okay, it covers some of the preventative services like exams or lab tests or screenings. Some people will automatically get Part B. Okay, in the beginning when they signed up. If you don't sign up for Part B when you first become eligible for it, if you wait till later, you're going to pay a enrollment penalty, a late enrollment penalty fee. So if you think you're going to need it, you might want to make up your mind ahead of time so that you don't get charged the extra penalty fee. Okay. If your modified adjusted gross income is as reported, like on your IRS tax forms for 2 years, it's above a certain amount, then you're going to pay more per premium. And the other drawback is the amount you pay for the Medicare Part B premium changes every year with your income. So that's something that a lot of older people don't know. I didn't realize, but you as the nurse can help educate them if you have that opportunity. Part C is Medicare Advantage Plan. We don't talk about it very much. You usually go straight to Part D, but it is like an HMO or a PPO, and is offered by private companies that are already met the Medicare or the federal Medicare requirements, and they can give you or insure you for this additional coverage, which will supplement on certain things. So in this case, the Advantage Plan may give you the private room, and the Advantage Plan may give you the ability to have a TV and a phone if it is a separate itemized cost by the facility. So that's something to think about. The only thing about that is it's difficult for the older adult to understand the insurance lingo, the mumbo jumbo about these plans, and to decide whether, which one will be the better for them. And there is a cost for them as well. Medicare Part D is the drug coverage that we are more familiar with. And you also pay a premium for this. So you're paying a premium for Part B, and you're going to pay a premium for Part D. Okay? Your actual drug plan cost to you will depend on the drug you use, the plan you choose. There are different plans to cover you in the network. Whether you go to a pharmacy that's in your plan's network or you go to an outside pharmacy, whether the drugs that you use are on the plan's formulary, whether you get extra help paying your Medicare Part D costs. So these are things to take into consideration that your patient may not know about, because these will affect how much the premium is, what will be covered and not covered. Doctors often put patients on maybe a new medication to help them and not realize that it is not in their formulary. So when the patient goes to fill a prescription or whatever, it's going to be a out-of-pocket expense. Most Medicare prescription drug plans have what we call the coverage gap or the donut hole. And you will read about this again in chapter 19 of the text. The donut hole. This means there's a temporary limit on what the drug plan will cover for the drugs. The coverage gaps begins after you and your drug plan have spent a certain amount for covered drugs. Okay, so in 2013, which is this year, once you and your plan have spent $2,970 on covered drugs, and that's combining the amount plus your deductible, you're in the coverage gap. And this amount may change every year. Also, people with Medicare who get extra help paying Part D costs won't ever have to worry about entering the coverage gap. Once you reach the coverage gap, you will pay 47.5% of the plan's cost for covered brand name prescriptions. So you get these savings if you buy prescriptions at a pharmacy or order them through the mail. Discounts will come off of that price that your plan is set with the pharmacy for a specific drug. So there's a loophole there. And remember this when we talk about Affordable Care Act. There is a little donut hole where their patient is going to be paying for medicines out of pocket. Now, in a lot of states, there are pharmacies such as CVS. I don't know if CVS does it regularly, but Walgreens and Drug Mart and certain grocery stores have drugs, generic drugs that are given to their patients, and they sell them to them for $3 a prescription, which makes it a whole lot easier and more affordable for them. But that's only generic brands. When it comes to a newer medicine or a medication that has not been released in a generic form, it's going to cost that older adult a whole lot of money. So there are things that are not covered under Part D that will end up being out of the pocket expense. Thus, you have older adults going to Canada to get medication, or we have the other issues that come with people who cannot afford their medication, such as sharing them, splitting the pills, skipping doses, hoarding them up for a rainy day, only taking them when they feel bad. There are things you can do to help your patient. You can see if they qualify for Medicaid coverage, for one, and we'll go into Medicaid in a second. Or you can actually write to pharmaceutical companies for the newer drugs, and the pharmaceutical companies will give prescription medications, newer drugs, for free to the person that's in need. So there are some things to get around it, but for the most part, it is a battle for a person on a fixed income and who has multiple medical diagnoses that require a lot of medication. Medicaid. Medicaid is a jointly funded federal to state health insurance program that helps many people who can't afford medical care for some or all of their medical bills. Patients usually pay no part of cost for covered medical expenses. A small copay is sometimes required in Medicaid. There are some states that have a Medicaid spend down, that after the person reaches a certain limit in their money, then that Medicaid card is released for that month, and everything else is covered from then on. Medicaid is a federal state program. That means it will vary from state to state. It is run by state and local government within federal guidelines. The federal government gives them the money, the state decides how it's going to be distributed and handed out to those who qualify. If you are age 65 and older, you should apply. If you're blind or disabled and have low income and few resources, you could qualify. If you are terminally ill and want to receive hospice services, aged, blind, disabled, living in a nursing home, low income, limited resources, and so forth, or you can apply. And you can't stay at home with any specialty community care, then you should apply. Medicare enrollees who have limited income and limited resources may get help paying for their premiums out of pocket by Medicaid, which is kind of what we were talking about earlier. There are QMBs and SLBs and QIs that will help pay for the Medicare premium that the person can get. So if you're low income, you qualify for Medicare, but you can't afford the Medicare premiums for Part B and D, then Medicaid may kick in and cover those premiums for you. It depends on your state as well. Some states also have Medicaid waiver programs for older adults. Here in the state of Ohio, they have it. It's called Passport Program. And so, once again, the federal government gave each state money for their older adults because it costs so much money for them to go into a nursing home, and to help lower that cost and allow the older adult to continue to be independent and autonomous, they gave money to each state, and they had to determine what they were going to do with that money to lower the cost of health care for the older adult. Here in Ohio and a few other states, they created what we call the Passport Program. They also have programs, different other PACE programs and a couple other programs. And what these programs do is provide services to help this older adult remain in their home. The qualifications is there's an income standard and an asset standard. The income standard is higher than traditional Medicaid. Traditional Medicaid, they may not have an income. Okay? Traditional Medicaid, they cannot own a car, have a house. In this Medicaid waiver for the older adult, they can. So they're a little lenient on the stipulations because it's going to cost them less in the long run. The person must also be 60 years and older and qualify for a nursing home, meaning they meet the level of care that would be needed to enter them into a nursing home. For anyone who's familiar with nursing home placement, for Medicaid to pay for nursing home placement, they have to meet a certain level of care, meaning they have to have a need in at least 2 ADLs, activities of daily living. So the person that gets this Medicaid waiver still needs this care, could be in a nursing home, but because we have given them an opportunity to stay at home and it costs less, then we can put in Medicaid home health aides to help them take their baths or clean or cook for them. Or we can put in durable medical equipment, transfer tub benches, and handheld showers to help them be able to give themselves a bath or a bath with some assistance. They can get home delivered meals as well. Okay, so there are different things that we can do for the older adult under this Passport Program, which is a Medicaid waiver program. This is not the same in every state. Remember, this is federal money that is controlled or under the guidelines of the federal government, but is controlled and distributed how the state wants to. Pregnant women, children, and teenagers also can qualify for Medicaid coverage. Medicaid covers additional services beyond those provided under Medicare, including nurse facility care beyond the 100 days. Medicare will pay for those first 100 days for a skilled nursing facility, but then that's it, and Medicaid can kick in. Medicaid will cover all prescription drugs, so there will not be any out-of-pocket expenses as in would be with Part D of Medicare. They cover eyeglasses and hearing aids. Services covered by both programs are first paid for by Medicare, and then Medicaid picks it up. So Medicaid is the payer of last resort. If there's other insurances or covers involved, Medicaid is always the payer of last resort. And there is different state limits that Medicaid will allow, and it varies between states. So now we'll look at some of the changes. The Affordable Care Act, there is not much information in your text about Affordable Care Act. There is a lot in Consult Jerry RN, which is one of your resource links, web links in your course of study. And I'm going to give you a little information here. On March 23rd, 2010, President Obama signed Comprehensive Health Reform, which is really called the Patient Protection and Affordability Care Act. It was made into law, so that means it is in force now. It focuses on provisions to expand coverage to Americans, control healthcare costs, and improve our healthcare delivery systems by increasing access, controlling costs, and increasing the healthcare workforce. Okay, Medicaid and Medicare require training for nursing assistants and aides in home health care, but for personal or home care aides or those who are being privately paid for or in group homes, traditionally had not received the benefit of training and certification until this law passed. So now they also will get immediate funding they'll get immediate funding for 3 years in up to 6 states. They're running like a pilot program. And then they will be re-examined to see how well this done, because we want all people who are involved in taking care of the older adults to have that special training and proof that they are certified in taking care of an older adult, such as they have to do for Medicare and Medicaid. The act also will allow federal government to require Medicaid and Medicare certified nursing homes to require dementia management and abuse prevention training. So they have to do that in the beginning of their employment and ongoing during their time of employment, like refresher courses or continued educational units. This act also authorizes grants and training programs for community health workers, community-based long-term care entities, and healthcare professionals who provide direct care. So what it wants to do is focus particular emphasis on targeting training programs to serve the underserved and the high-risk communities and populations. The act wants you to be aware of these special needs groups and to be able to treat them accordingly, accurately, precisely, efficiently. This is a state insurance exchanges will be available to direct care workers and their families with tax credits available to those who qualify. It will eliminate pre-existing condition exclusions where you can't get insured because you already have diabetes or high blood pressure, so they will deny you insurance coverage because of pre-existing illnesses. The Affordable Care Act will eliminate that. The Affordable Care Act is also designed to get rid of that lifetime cap or that annual cap on benefits. And so it also is looking at improving data collection from the direct care workers. And these data collection that they collect, the information that they collect from this will help change policies in the future. It will demonstrate a need for change. In addition, you have what is called the Class Act. This is the United States Public Long-Term Care Insurance. This plan is based on automatic payroll deduction, and the worker or the employer can opt out of it, but it is available to any worker who is 18 years and older. And anyone who wants to participate becomes eligible for service after paying in the premiums for 5 years. So if you have something that causes you to need long-term care services, you are eligible once you have paid into the system for 5 years. Eligibility depends on having a licensed health professional determine that an enrollee has either cognitive or functional impairment that is expected to last more than 90 days, supports community living for the beneficiary with long-term care, cognitive and functional impairments. It also provides a modest benefit to cover non-medical ADL services and support. The first choice option allows individuals who are eligible for institutional care to receive community support and services if the state chooses this option with an enhanced federal match of 6%. This will make home care based services more flexible through the state plan amendments rather than through the waiver that I talked about before. The demonstration project is the Department of Health and Human Services will award one or more competitive grants for up to 3 years. Both projects must consider the special needs of those living in the community. It proposes a variety of models and incentives that expand Medicaid coverage and promote community-based care. So, keeping these people at home does pay off. It is a whole lot in less cost to the government and Medicaid services. So it's going to be in lieu of nursing home placement. So it includes people who have cognitive impairment, including dementia. So what this act is going to do is make it so that each state is not in charge of this money per se, but there is funding that will be available for those who qualify to keep them in their home and to provide them services that will guarantee their safety and their quality of life, instead of each state doing a waiver program. That will no longer be needed. So now the home health agencies that do the home care will be under a little bit more pressure. They're not liking this, but they're going to be under pressure to really manage the costs. They're going to have to look at nursing costs, case mix, utilization of services very closely. So right now it's, some concerns going on about the potential impact and the access and quality of home care that's going to be available. And like with anything, when there's change, there's a lot of people and entities that are not really acceptable or don't see the benefit that it would be for them. And so, depending on the agency, especially those who are for profit, this is going to affect their profit. There also are mandates. The Affordable Care Act mandates 2 studies. The first one is due in January 2015 to assess this impact on home care. So they're going to look at the reductions in access. They're going to look at quality and number of agencies and the types of agencies. The second study is going to be due. The second study has already been done, and it was used to evaluate the cost of how much it costs to serve the low income and people who have very complex care needs, and how have they been, what is the pattern of readmission into home health care to hospital care and back. The act will authorize up to $500 million based on study findings and demonstration to see if there is a change needed. The whole Affordable Care Act wants to improve health service delivery, outcomes, and population health, emphasize on management and managing high costs, chronic illnesses, reducing preventable hospital admissions, and decreasing health disparities. There is one law that I'm kind of familiar with, that is serviced under Affordable Care Act. If a patient goes into the emergency room, say tonight, and has a complaint and is treated and sent home, if that patient returns the next night with the same problem, then the hospital facility must absorb the cost. The meaning in the theory being that if they had treated the patient correctly the first time, they should not have to come back in 24 hours. And if they need to come back in 24 hours, perhaps the hospital should not have sent them home, but it admitted them to the hospital either as total inpatient or either for 24-hour observation. So this is to, one, keep the hospitals from collecting on multiple visits into the ER for the same thing. To two, make sure that they are treating the patient closely and more accurately to what's going on. Now, I can see where this could be a problem for a healthcare facility in an example such as a patient with asthma comes in, gets the treatments, clears totally up, looks good, blood gases are good, no more wheezing, breath sounds clear, goes home. Perhaps maybe they go back to smoking that we don't know about, or around a pet or any other allergen, and they have the same thing attack again, come back in to the ER the next day. Is that the hospital's fault or is that the patient's fault? So this is where the hospital facilities are arguing about this new ruling. So I will just have to watch and see how that plays out. Affordable Care Act does something for drugs as well. For generic drugs, there will be a federal subsidy of 75% of the generic drug costs. So 75% of generic drug costs will be in place by 2020 for prescriptions that are filled with Medicare Part D, thus covering that donut hole or that gap that was phased in beginning to be phased in around 2011. I'm not sure if anyone has actually noticed it or seen it. I have seen different things around locally that have to do with pharmacies fulfilling drugs. Drug costs at some places now for generics have been decreased to $1.99 per prescription. And so you may be seeing that in your area as well. But that is going to be completed by 2020. Medicare has already decided that the large doctor groups, those with 100 or more doctors, nurses, social workers, and health professionals will gain and lose as much as 1% of their pay starting in 2015. Another big thing, a lot of argument with doctors' offices because they don't want to lose any of their money. But their incentives for the smaller ones would double to 2% in the following year. Okay. The proposal would phase mid-sized physician groups, those with 10 to 99 health professionals, into the program around 2016. So there's a gradual phase in instead of 2017. So it's a little bit sooner than they thought. And they would be eligible for bonuses up to 2%. Okay. And they will be shielded from penalties for that first year. So they'll give them an adjustment time because they will have penalties and loss of reimbursement fees. In 2017, the program would add the remaining doctor groups in those doctor groups that have 9 or fewer. So that's about 350,000 doctors, according to what the Medicare is estimating are going to be infected. The bonuses and penalties that were formerly known as the physician's value-based modifier will be calculated on quality measures that are very specific by the doctor's specialty area. These are going to check how often the doctors follows basic medical approaches such as screening older women with fractures for osteoporosis, documenting in medical records every drug a patient is taking, and at least at a start, the doctors will be able to select which of the Medicare measures they want to be judged by. This is going to hold some of the doctors accountable. Everything is going to have to be documented. All I's will be dotted and all T's will be crossed. And so we're looking at how well they're servicing older adults as far as preventive measures. Or are they just treating and sending them out and retreating and sending them out and so forth? When it comes to money, I think that is one of the ways that it's going to be the incentive to get doctors to comply with the new regulations. The Affordable Care Act fills in current gaps in coverage for the poorest Americans by creating a minimum Medicaid income eligibility level across the country. Not by state as it's been, but for the entire country, it will be the same. Beginning January 2014, individuals under 65 years of age with income below 133% of the federal poverty level will qualify. Used to be 129, I believe, percent of the federal poverty. This will create a national Medicaid minimum eligibility of 133% of the poverty level. So if it's a family of 4, $29,700 a year for nearly all the people under the age of 65. For the first time, low-income adults without children will be guaranteed coverage through Medicaid in every state, which it was not the case. There won't be a need for a waiver. Parents of children will be eligible for the uniform income level across all states. Medicaid and children health insurance programs, CHIPS, eligibility enrollments would be much simpler. And even though that's not what we're dealing with older adults, I just wanted to throw that in so that you can have a more overall view of what the Affordable Care Act is all about. So it's going to make some big changes here for them. Okay, and if you have any questions about this PowerPoint, feel free to give me a call. I'm at extension 4009 or my email, barbara.dantzler@wgu.edu, and I will be very happy to help you and assist you. Thank you for watching the video. Again, watch it as many times as you would like, and good luck to you.